Anyway, this man is somebody that I know very well. He's one of my best friends. I know him because he came just 1 year after me from during College of Medicine days and OBGYN residency days. So of the University of the Philippines College of Medicine class 1986. He took up his residency in OBGYN at the PGH and was chief resident in 1992. He took up his fellowship in Belgium in infertility and reproductive medicine at the Free University of Brussels under the tutelage of one of the greatest IVF specialists in the world, Professor Paul Devery. He took up also his master's in biotechnology of human-assisted reproduction and embryology at EV Valencia, Spain. And of course, he's a recipient of this Professorial Chair Award. Down, please. He's an Associate Professor 7 of the UPPGH. Of course, he's in the Division of Reproductive Endocrinology and Infertility. He's currently serving as member of the Board of Trustees of the Philippine OBGYN Society. Presently, he's chair of the Committee on Scientific Works. He's a Board of BOT representative of the POG's Unified Research Agenda Ad Hoc Committee. And he was a member of the Philippine Board of OBGYN. He's past president of the Philippine Society of Reproductive Medicine, that was in the year 2010, and currently sits as the board chairman of the ART Regulatory Board of the Philippine Society of Reproductive Medicine. In 2019, he incorporated and founded the Philippine Society for Fertility Preservation. That was September of 2019. He's a board member of the Philippine Society of Gynecologic Endoscopy from 2011 to 2014. And he's founding president of the Philippine Society for Fertility Preservation. On the international scene, he is a treasurer of ASPIRE, which stands for Asia Pacific Initiative on Reproduction. He's a board and founding member of the Asian Society of Fertility Preservation. Indeed, he's a key figure in the initial conceptualization, designing, development, operationalization, and current management of CARMI, which is the IVF Center of St. Luke's. It stands for Center for Advanced Reproductive Medicine and Fertility. Down, please. Ria. On a fertility preservation program in the Philippines. Ladies and gentlemen, let me call on a good friend, a wonderful husband and father and grandfather, Dr. Virgilio Novero.
Thank you, Eileen. Let me just set up my slides.
Joy and I were just saying that it's so much easier to talk in front of a huge audience of 1,000, 2,000. So this is really a challenge, this webinar. Yes, so now we have the slide.
Hang on. I'm supposed to, there you go. All right. Okay, thank you. Thank you, Eileen. Good morning, everyone. And thank you, Eileen, for my kumare for that kind introduction. I'd like to start by thanking our chairman, Dr. Efren Domingo, for nominating me to this Augusto M. Manalo Professorial Chair, something I consider very prestigious. I feel further humbled that I knew the man himself, Dr. Augusto Manalo, for I was the 5th of 7 chief residents during his 2 terms as chairman from 1988 to 1994. Being the kind-hearted, down to earth and as chief resident in 19, Dr. Manalo was always there to oversee you as his son. Be firm when you are a bit. I'm sure all the other chief residents under his term, like Dr. Domingo, Dr. Festin, Dr. Macarubo, Dr. Shiasu, Dr. Hernandez, and Dr. Habana, know exactly what I'm talking about. My respect for Dr. Manalo as a professional and as a person is immense. After I graduated from training, he would always ask how I was doing, and he would never forget giving Christmas gifts every year despite his lofty stature. Finally, he would always remind how we should always remember to give back to the department and to the UP whatever we read. For those reasons and lessons, I feel humbled to deliver this Augusto M. Manalo Professorial Chair Lecture to honor a person that I truly admire. The title of my talk in honor of Sir is Setting Up the Fertility Preservation Program in the Philippines. To some of the guests, they may be wondering why they would be invited in a talk which is largely fertility or reproductive medicine, given I will explain how you may be part of this advance so far and what we still need to do of sites, sperms, or reproductive tissues so that one is potentially able to use them in the future. This is an exciting new discipline to keep up with the progress in other fields, including cancer therapy. There is now an increased demand for fertility preservation services worldwide. It started with young cancer patients, and it has now expanded to various other conditions. There are parallel histories that have married cancer therapy and reproductive medicine. With the Cancer Act in the US in 1970, there was a quick progression in improvements in cancer therapy, increasing cancer survival for the next 5 decades. In the field of reproductive medicine, after the initial discovery of slow freezing of sperm, later with the first IVF baby of 1978, there were rapid advances in the field of ART, culminating with the discovery of vitrification eggs and oocytes at around 2007 and 2008. With these two being married, the field of fertility preservation was formally opened with the inauguration of major international fertility societies, FertiProtect, ISFP, and the OncoFertility Consortium, and further expanded with other indications for fertility preservation, non-oncologic reasons and social reasons in the coming years. But the main driving force for fertility preservation is still cancer, and it is anchored on the improvements in the cancer survival of patients, which has doubled the 10-year survival the past 5 decades. If they don't get treated, there is a decline in an average of about 30 to 40% in patients with cancer. And among the most common cancers, breast cancer, the decline for the chance for pregnancy is about 70 to 80%. There are other cancers among adult women that have been mentioned, many surviving long, like melanoma, breast cancer, gynecologic cancers, and the hematologic cancers. The figures are even more impressive with children, with an average survival rate of about 80%. These include your retinoblastomas, your gynecologic cancers in female children, your hematologic cancers, and your soft tissue tumors. If you look at the series of patients where fertility preservation is done, 72% are cancers and 28% non-cancer for the age group 19 to 35, whereas it is nearly 50-50 for the younger age group of 3 to 18 years. So if we consider that patients who are diagnosed cancer will go forth with cancer treatment, we expect there will be a lot of cancer survivals. But that also would mean they would be after an improved quality of life, which would include questions about their infertility, which has been identified as the single biggest concern among young cancer survivals. So if you take a closer look at the cancer therapies that are given to them, you can almost predict the amount or the chance or risk of infertility depending on the type of chemotherapy or radiotherapy that would be given. Those with high risk for chemotherapy include your alkylating agents like busulfan and cyclophosphamide. Those with an intermediate risk of a 20 to 80% infertility risk would include your doxorubicin, your cisplatin, your carboplatin, and the like. And those with a lower risk include your actinomycin B, your vincristine, and your methotrexate. The same is true for risks of infertility related to radiotherapy, both for males and females, depending the amount of grade that will be delivered to our patients, giving them either high risk or intermediate risk for infertility. But it is not only the dose that will be given. I did already mention it will probably be among the strongest toxicity risk, followed by the various groups of chemotherapeutic agents. What would there's a big higher ovarian left because each insult normally translates to about 7 to 10 years of decline in your ovarian reserve. If you give your insult when they're older, when they're about 40 years old, they will almost surely go into POI. The same is true for your gonadal damage, gonadotoxic damage to the testicles in males. The Leydig cells are the most resistant, and the most sensitive are your spermatogonial stem cells. So when you apply insults like chemotherapy or radiotherapy, depending on the dose that you give, it's possible that boys may develop normal puberty, but they are actually infertile. Yet similar that providers has the possibility of infertility before gonadotoxic are complicated. Option of ovarian cortex biopsy and the strips of ovarian tissue, allowing them to conceive either by natural conception or by IVF. In choosing the strategy for females, we will work within the time limit set by the oncologist, the so-called fertility preservation window. If we have 2 weeks or more, then we can do embryo or egg freezing. For hormone-sensitive cancers, we decide to give letrozole to keep down the estradiol levels. And there are various protocols designed to shorten the time required. If we have less than 2 weeks, we may choose ovarian tissue cryopreservation. And if the patient does not choose any of these, another possible choice would be, although still considered experimental, GnRH agonist co-administration during the chemotherapy. The procedures for embryo and oocyte cryopreservation have been previously described. In a nutshell, after 2 weeks of controlled ovarian stimulation, they undergo ultrasound-guided oocyte retrieval. Those with partners will be stored as embryos, and those single will be stored as oocytes. And just to be reminded, for a long time, mature oocyte cryopreservation was not recognized as established. It was experimental for the longest time, but in 2013, it was declared to be no longer experimental and now an established procedure. But the new kid in the block is ovarian tissue cryopreservation, which was for the longest time considered experimental. In November 2019, however, ASRM declared them as no longer experimental because this is an efficient way of preserving thousands of ovarian follicles with over 130 live births all over the world. So it was now considered an established procedure. The steps for OTC have been described. After an initial oophorectomy, the, the ovarian cortex is trimmed down and you have strips of ovarian tissue in 5 by 10 sizes. They're frozen by vitrification or slow freezing, and once they're needed to be reimplanted, they're thawed and placed and transplanted following various techniques. Prior to transplantation, their viability can be assessed by staining, as is shown here. You can see the viable follicles in figure C. Now, once you assess them for transplantation, they can be placed in subcortical pockets under these cortex in your ovary. They can be sutured over the medulla in your ovaries, or they can be placed in peritoneal windows. Just to show you the proportion of patients with that undergo these procedures in this series in Belgium, 80% of their cases of fertility preservation was undergoing OTC, and only 20% was undergoing oocyte or embryo cryopreservation, seemingly showing a shift towards OTC instead of ovarian stimulation to get eggs and embryos. In the males, it's a lot cheap, it's a lot simpler. Of course, the easiest way to get to do your cryopreservation is to collect sperm by masturbation and keep them in storage. However, in some males where it is impossible to collect them normally, then you can do surgical sperm retrieval. For those who are immature, they will be stored as immature testicular tissue. And for those mature, they'll be kept in storage and they can be used following the IVF-ICSI technique. So in the preservation options for men, it is simply after masturbation, which is the easiest, cheapest mode of fertility preservation for men. However, there are collection procedures in those where this is not possible, like by electroejaculation and various techniques of surgical sperm retrieval. Going through the strategies for children, you only have one for each. For prepubertal boys, you have immature testicular tissue cryopreservation as an experimental procedure. And for immature girls, you have ovarian tissue cryopreservation as an established or accepted strategy for children. For boys, 75 to 85 of them are expected to survive the cancer. But we do not have an accepted strategy to store future gametes. Right now, we can only collect spermatogonial stem cells in its immature form, but academic centers are currently preserving their testicular tissue in anticipating that the spermatogonial stem cells can be used in the future. Right now, there are ongoing studies on how to find ways to mature these spermatogonial stem cells, either by propagation or differentiation, in vivo or ex vivo, or even xenografting. Let's talk about another group of patients that require fertility preservation. These are your non-oncological diseases, where few efforts have been given to this group. They say this group represents about 8 to 15, up to even 20% of cases for fertility preservation. So it is important to recognize, counsel, and give adequate management for these patients. This table given recently describes the non-oncologic conditions that require fertility preservation. These are autoimmune diseases like SLE, granulomatosis, rheumatoid arthritis in the severe forms, those that require hematopoietic stem cell transplantation, like various hematologic diseases like sickle cell anemia, thalassemia, and aplastic anemia, and various medical conditions like mosaic Turner's, galactosemia, thalassemia, and Klinefelter syndrome. This series from Denmark shows that a lot of these rare genetic diseases have been cryopreserved at a very young age, average age of 10 years old, 23 years old, 4 years old, 11 years old. We will need a lot of help in diagnosing and identifying these patients. In this series from Professor Anderson in Denmark, there are different types of diagnosis indicated for fertility preservation by OTC. A different set for 0 to 12, 13 to 18, 19 to 25, and 25 to 43. In the older age groups, of course, you will have your breast cancer patients. But in your younger age groups, you will have your hematologic, malignant, and benign conditions. Again, as a reminder, ovarian tissue cryopreservation has been proposed principally for pre-pubertal females. And I will explain to you in a bit why we are discussing this. For instance, for benign hepatologic diseases, where involved are your thalassemias, your sickle cell anemias, or Fanconi anemia, those with high-risk causes will require conditioning chemotherapy prior to hematopoietic stem cell transplantation. This means they will also be given alkylating agents that will drop down their fertility. So they will require oocyte cryopreservation or OTC for prepubertal girls. And these are just your prime examples that prepubertal OTC does work. These are the only two cases where prepubertal OTC has resulted in pregnancies decades later. Case one was a case of sickle cell anemia diagnosed at age 5. She needed to undergo hematopoietic stem cell transplantation at 13 years old, so they did OTC then. They gave her chemotherapy busulfan prior to the HSCT, transplanted the frozen cortex strips at age 25, and she had menses 4 months later. She separated from her first husband. 2 years later, she had a spontaneous pregnancy with a new partner, and they even had a second baby a year later. The second case had her OTC at 9 years old as a case of beta thalassemia. She had a left oophorectomy at age 9. And then, of course, they did her total body irradiation and immunosuppressive chemotherapy, and had her transplanted strips of ovarian tissue at age 23. She had spontaneous ovulation 4 months after, and had an expedited pregnancy after IVF a few months later. So there are other conditions that may also be indicated for fertility preservation. Autoimmune diseases like SLE may require immunosuppressive therapy, like using alkylating agents as cyclophosphamide, which will cause a risk of 60 to 80% risk of POI. So these patients are mostly treated with ovarian tissue transplantation. Fertility preservation has also been suggested for endometriosis. And in these patients, because of accelerated loss of follicles, they suggest that these patients should probably undergo OTC, or they should probably undergo either ovarian stimulation for egg retrieval or embryo cryopreservation. In the only case series of 49 patients, they're mostly with deep infiltrating endometriosis and endometriomas, but they had decreased response to stimulation, suggesting that the stimulation should happen before endometrioma surgery. In this protocol suggested by Liarena, she suggested that those with bilateral endometriomas and those prone to multiple surgeries or those with low ovarian reserve are candidates for fertility preservation. Even those with borderline tumors of the ovary have been suggested for fertility preservation. They say that they have a 20 to 30% chance of recurrence. So because of this, their risk of recurrence, they are potentially better off that you would cryopreserve their frozen eggs, their eggs or their embryos. The final group will be your genetic disorders, which comprise about 10 to 12% of patients with premature ovarian insufficiency. Unfortunately, most are diagnosed when they're already having their primary or secondary amenorrhea. So the best is really to identify them real early, either by physical exam, by your non-invasive prenatal testing, or even by newborn screening. In this table given by Condorelli et al., those with accelerated ovarian senescence are in the groups of those with Fragile X, Mosaic-Turner syndrome, BPES, and galactosemia, where either oocyte cryopreservation or OTC may be indicated for these patients. Those patients with BRCA carriers, because they stand to benefit from bilateral oophorectomy by age 35 to 40, seem to have accelerated ovarian senescence. So they should undergo oocyte and embryo cryopreservation beforehand. Those with a family history of POI have a moderate to high risk of infertility soon with accelerated ovarian senescence. They too should undergo oocyte and embryo cryopreservation. But there are a lot of barriers before we could conduct our fertility preservation in these patients. Healthcare professionals, many of them avoid discussion because of wrong information, are completely unaware, or they have a sense of urgency to carry out the cancer treatment. Young cancer patients also avoid discussion because they are overwhelmed by the cancer or unaware of the consequences of the treatment. And then there are financial barriers. So we need to overcome these barriers with a lot of counseling. And with proper counseling, if you do it properly, if you counsel by the team of the oncologist and the fertility specialist, the regret scale is less. If you again counsel them by a team of your infertility specialist and your oncologist, their satisfaction with life is much better. Let's talk about what we have done in the local scene. At the start, soon after the Oncofertility Consortia were created, we were just giving isolated lectures on fertility preservation here in the Philippines. These were done in various societies. In 2015, we decided to go to Japan to try and learn ovarian tissue cryopreservation in a workshop as an institution. And we met Professor Nao Suzuki, who was then doing his researches on in vitro activation of ovarian tissues. Then we realized he was already conducting a lot of seminars for ovarian tissue cryopreservation. We brought home the knowledge and we established the first fertility preservation committee for men and women in St. Luke's Global, which was the first multidisciplinary group for fertility preservation locally, marrying together specialists from reproductive medicine and oncology. A few months later, we decided to hold the first international ovarian tissue cryopreservation workshop and symposium in early 2016 with the help of esteemed faculty, Professor Anderson of Denmark, and again, the Japanese group led by Professor Suzuki and Seido Takei. Later on, we would report the first cases of ovarian tissue cryopreservation in the Philippines. And later on, we would be showing the first case in this video where after oophorectomy, we would trim down the ovarian tissues to the cortex and form strips of ovarian tissue for freezing. For the moment, we have 10 cases of ovarian tissue cryopreserved in our freezers, but none are candidates so far for transplantation. Subsequently, the following year, Dr. Delphine Tan organized the first Oncofertility Joint Symposium in St. Luke's Global, in St. Luke's, Quezon City and Global City. And subsequently, with the auspices of Aspire, we held an international workshop on male infertility, which included testicular tissue cryopreservation early last year. And finally, we were just lucky around the time that we were about to open the Philippine Society for Fertility Preservation. The Department of Health met with the Philippine Medical Association and various oncologic groups because they were about to launch the Philippine National Cancer Integrated Act of 2019, and we were luckily invited. So with this, we were able to incorporate fertility preservation in the protocol of treating cancer patients. So for young patients who were diagnosed early, they would now be included for fertility preservation prior to cancer treatment. And then finally, the Philippine Society for Fertility Preservation was inaugurated in September 2019, where we had 169 founding members from multiple specialties and our board of directors. We became the fourth Asian country with a dedicated fertility preservation society in Asia. The goals of the society are, of course, quite easy to deduce. For the practitioners, we need to improve knowledge and skills, increase awareness, create a referral system and network, and conduct FP research. We also need to improve the capabilities of the IVF centers and increase awareness in the general public. We do know that 10% of cancers that are diagnosed will belong to the reproductive age group, and that translates to approximately 15,000 to 18,000 cases that may require fertility preservation per year. We have 7 IVF centers to serve these particular conditions, and more IVF centers are expected to be set up in the coming years, hoping to serve all cases that will require fertility preservation. We are now presenting our initial studies on fertility preservation, this one by our recent graduate, Dr. Patricia Ann Factor, last year on her study on the knowledge, attitudes, and practices of Filipino clinical oncologists regarding fertility preservation. She found that most have no exposure to FP options, most are aware of the options but have minimal knowledge, and most have never referred to a fertility specialist. And they concluded that there is an acute need to increase knowledge and awareness about fertility preservation methods and international guidelines. We are also part of an Asia-wide study on fertility preservation following the same findings of Dr. Factor. And I recently wrote a review about fertility preservation in the Philippines, and I submitted this for publication, and we're awaiting its acceptance. But important for now is really to increase awareness. We've been doing our rounds with the various oncology groups, and this would already be the 3rd webinar on fertility preservation. I would like to call your attention, though, to the one that we did 2 weeks ago, where we had a partnership with 5 other oncology groups. Interdisciplinary partnerships will be key to the success of fertility preservation. Finally, lots of information materials will need to be given to our patients, like frequently asked questions. This one we will be distributing to the various clinics of oncologists and fertility specialists, to all clinics for free. Also, we need to network with private NGOs so that they will help us spread the word about fertility preservation. This one we linked with the I Can Serve Foundation. And internationally, we also need to link with the various networks for fertility preservation. And I'd like to emphasize on our linkage with the Asian Society for Fertility Preservation, which was established in 2016 by the same Professor Suzuki, who we were honoring a while ago, to help us learn OTC. This is to promote the science and practice of fertility preservation at the Asian level, and this was at the inaugural meeting in 2016. We were also included as a member of the board. It is also important to have more members of our staff to learn formally about fertility preservation. We have sent one of our graduates, our fellows, Dr. R.B. Jane Igualada, had a 6-month full fellowship in oncofertility at the St. Mariana University, where she performed various skills in oncofertility and made some research also on oncofertility. Another important aspect of fertility preservation management will be to have formally trained counselors. And this is what we also did. We sent one of our social workers for a formal 10-month online course for fertility preservation, fertility counseling, which includes fertility preservation. And she becomes the first Filipina formally trained fertility counselor. We have to send more of these to help our patients understand and get through fertility preservation. So what else needs to be done? Fertility preservation is at the infancy stage in the Philippines. I already mentioned that we have about 15 to 18,000 cases that we can scour and offer fertility preservation. And after our initial awareness campaigns, we have some increase the past few years, especially our young cancer cases. However, the non-cancer referrals have not yet started. The social freezing portion has definitely increased. So we need a sustained effort to catch a significant portion of these patients. So as I mentioned, we have to identify the gaps, educate, increase awareness of our healthcare providers, the patients, the paramedical counselors, and probably suggest to include fertility preservation in the training curricula. We have to understand our patients more by doing research and probably starting a registry of cases and get more like-minded people involved, get more partners transcending the disciplines, train more consultants, new fellows, and centers. And then we have to take care of certain issues administratively, like cost and the referral networks. When we screen for our patients for fertility preservation, these are already divided as 80 to 85% those with cancer and 15 to 20% not related to cancer. And those are outside those which are indicated for social reasons. I was going through the figures of genetics and genomics in the Philippines, and I tried to identify the amount of material that we can potentially identify at a very early level. So from this paper by our chancellor and vice chancellor, they have already seen 261 Turner syndrome variants, hopefully the mosaic syndromes, in the past 25 years. In their metabolic registry, there is a significant amount of galactosemia. And in newborn screening, again, there's a lot of galactosemia and benign hematologic diseases. All of these potentially requiring fertility preservation. So we will need multidisciplinary alliances with our oncologists, our reproductive medicine specialists, our primary physicians, OBGYNs, pediatricians, surgeons, family physicians, and all others, including the paramedicals, and set up multidisciplinary cooperation for this new developing field, fertility preservation. But we also need to address the issue of cost. The male infertility strategies are more affordable than female fertility preservation strategies. The cost of embryo and oocyte cryopreservation is quite substantial. They approximate the cost of ART. OTC will be based on the cost of the laparoscopic procedure of the center, and there is a significant cost for OTC processing for the IVF labs that do them. We have to explore cheaper protocols and hope that the National Integrated Cancer Control Act may provide enough funds for many of our patients. We need to have more of our fellows trained in fertility preservation in their known centers in Japan and Denmark. And there are others available in the US and also in Israel. And we need to promote research in the local and international fertility preservation. We have to understand the local issues in fertility preservation. And we have a few ongoing and planned research right now. One of those is the possibility of freezing testicular tissues in prepubertal boys. And with the efforts of Dr. Nico Magsanok, one of our pediatric urologists here in UP, he has already linked with a group of Pittsburgh with Professor Orwig and his classmate, Yasmin Gosenkiao, who happens to be one of the leaders of the infertility consortium in the US. And with that, we may be starting the storage of prepubertal testicular tissue to try to cryopreserve spermatogonial stem cells, waiting for the progress in ongoing studies to mature them from spermatogonial stem cells. And waiting for the visions of the National Integrated Cancer Control Act, where they plan to integrate, to have and set up regional cancer centers. We have to match them with IVF centers near all those regional cancer centers so that there will be an efficient referral system for these cases of fertility preservation. We'd like to follow the models for fertility preservation networks of Japan, and there's also another model in Denmark, which we can use as a model so that we could establish the own Philippine system of referring fertility preservation cases. That was my last talk. That's my last slide. There's a worldwide trend for the promotion of the rapidly evolving field of fertility preservation. There's an acute need for fertility preservation in the Philippines, with about 15,000 cases of cancer per year, plus another 3,000 or so non-cancer patients that will benefit from fertility preservation. We need a sustained effort to spread awareness about fertility preservation and inform both healthcare providers and patients of this new field. And all physicians must be armed with information about the future fertility in the treatment of oncologic and non-oncologic conditions so that affected patients may be counseled ahead of treatment and referred to a reproductive medicine specialist. I'd like to acknowledge the help of the team who have been really giving a lot of effort for fertility preservation. These are members of the PSFP and the PSRM, and I'd like to acknowledge them in name: our moderator, Eileen, Gladys, JJ, Nay, Nico, Dennis, Ricky, Badong, Dr. Alyave, and Michelle. All these very active in trying to promote fertility preservation. And we need more to help out. All the members of the other societies who have recognized the need and have extended themselves to help. And the members of the St. Luke's Medical Center and the UPPGH who have given their unwavering support despite the demands of various other professional responsibilities. With that, I thank you very much.
Thank you, Dr. Joy Novero. That was a wonderful, very comprehensive, and very impassioned lecture on fertility preservation. I know that we have in our midst Dr. Na Suzuki from Japan, also members of the PSFP. We have Nico Magsanok. We also have Dr. George Ignacio, head of the PGH Cancer Institute. So we only have a few minutes left, and before we say goodbye to everybody, maybe we can just open the floor to some questions. I have a few